Welcome to Dental Expedient. My name is Thomas Han. I want to share with you a immediate flapless implant surgical technique that has worked well for me, that I have thought of, that addresses some of the problems with immediate dental implant placement. As you know, the placing implants immediately after the extraction is still a little controversial. There are very reputed clinicians who says that we should not do it, and there are reputed clinicians who says that we should do it to preserve the vertical height of the aesthetics. And the literature today shows that both delay implant placement and immediate implant placements are equally clinically successful, but because when we place the implant in the immediately extracted site, we are placing an implant in a sort of movable foundation. So some of the long-term stability of the gingival margins, both vertically in interproximal area as well as the interradicular area, where the labiogingival margin is in question. And before we talk about this, there is also some controversy as to when we place these implants immediately after extraction, do we need to place bone graft or not? I think if you look at the literature, generally speaking, the most literature says that we should place the bone graft not so much to form bone around the extracted socket, but maintain the horizontal component to the extracted socket, because placing implant itself does not preserve the socket. So with that said, one of the main problems with placing implants immediately after extraction is a mean recession in the mid-facial area. And if you look at the literature's mean recession is about 1.1 millimeters if you look at 3-year period, and the range is anywhere from 0 to 2.5 millimeters. But if you look at some of the most recent literatures, if you have a thin biotype, you're going to have a greater recession of about 1.5 millimeters, where if you have a thick biotype, the mid-facial recession is less than 0.5 millimeters. So if we have a thick biotype, it'd be better for long-term stability of the aesthetics. Then if we have a thin biotype, does it exclude you from placing implants immediately, is the questions. And with this technique that I'll be describing that I thought of, I think we can place these implants immediately, even in a situation where you have a thin biotype. You know, there are a couple of literatures today using connective tissue for biotype enhancement. One of these techniques is a socket seal surgery described by Landsberg in 1997, which provides for seal graft, and he placed these implants in a submerged fashion. And the other one that is described by Kahn in 2005, where bilaminar subepithelial connective tissue grafting, and this also provides thick biotype. But one of the disadvantages is that it requires a very large connective tissue. But the advantage is that this technique is utilized in a non-submerged immediate situations. So my technique it enhances biotype, and it compensates for apical osseous positions, and also supports interproximal and vertical height of the gingiva or in the implanted site. So let's look at this situation where the root has been extracted, and the socket needs to be cleaned out completely, and the epithelial margin of the extracted socket is rimmed out, either using blade or you could use a diamond burr to do that. And then implant is placed in a more palatal position, so that if possible there's a direct contact between the implant surface and the palatal bone. and try to obtain maintain about 2 millimeter of socket from the labia bone. And that void is packed with some type of mineralized bone graft material. In this case, it's a freeze-dry bone. Many people use a hydroxyapatite or a xenotype of grafting. And if you prefer, when you're using xenograft, you could mix with a tetracycline solution. I have used this freeze-dry bone without using any type of antimicrobial agents, and works well. So this bone graft is packed to about 3 millimeters from the gingival margin, and then a connective tissue graft with epithelium intact in a crescent shape fashion is removed. And the thickness of this crescent shape graft is about 3 millimeters and usually follows the contour of the palatal outline of the tooth. So this crust, and then the width of this graft is about 3 millimeters in width. And then, as I said, this is about 3 millimeters thick. And this connective tissue is placed after the implant abutment, healing abutment, usually 2 millimeter healing abutment is placed. This graft is squeezed into this void over the bone graft in the labial portion of the healing abutment. And so this, the connective tissue graft receives its blood supply from the epithelialized socket area, and certainly it's not going to receive blood supply from the healing abutment. So there has to be a good contact along the outer parameters of this crescent-shaped connective tissue graft. And having this graft a snugly fit in place maintains a good contact between the recipient site and the graft material itself, which is very important. And then it is to maintain the blood supply during healing. The suturing is fairly important. And I think it's very important. So you could take 5/0 gut suture, and if you do this under the microscope, then I guess you have a better visibility. But I have done these without microscope. And you take 5/0 gut suture, and you enter from here by holding on with the forceps so that it doesn't squeeze out as you go in with the suture needle, and you go in through here, come out through the outside, the flap, and make interrupted knot. It's a simple interrupted suturing, and then you can go ahead and anchor it to the palatal area. So you need one suture here at the mesial line angle or distal line angle. You need one suture at the midline angle, and then you will need one suture at the mesial line angle. And with anchoring, it will hold this connective tissue graft firmly in place in direct contact with the recipient site, and this will ensure blood supply to this graft material during healing phase. Now, and you could see this with 3 sutures or even 4. This is a 1-week healing before the suture removal, and this is a healing after the suture removal, and this is about 3 weeks after the implant placement. You could see that the biotype has been enhanced, and it's difficult to see in this viewpoint, but the gingival margin has moved coronally. I want to show you this next case that I didn't place the surgical sites, surgical photographs, but this is after the healing, with immediate extraction and implant placement. But you could see that this is the original gingival margin, whereas this is the final gingival margin after the healing. And this is 1 year after. You could see that gingival margin has been moved coronally from the original gingival margin with enhanced biotype and very stable gingival margin. So this technique is very effective in enhancing the biotype and maintaining and even enhancing the original gingival margin at the midfacial level. And we have cases going 2 years with this technique, and we're seeing a very good stability and enhancement of the midfacial gingival margin and not recession. I want to share with you one more case, and this case study with implant placement in a edentulous area with combination of roll technique, where implant is placed and the palatal tissue was rolled to the labial side, and to enhance the biotype and maintain the interproximal tissue. And implant was placed in a one-stage fashion, and then final restoration was placed on number 8 position. A couple of years later, the tooth adjacent to it, number 9, also fractured and required immediate implant placement. And then this is the situation where number 8 is a restored implant restoration, which is this, and then number 9 was fractured, and we're replacing the implant. So tooth was extracted, and the technique that I described in the first part, where we go ahead and remove the gingival epithelium with a blade or diamond burr, and then connective tissue, as I described, is removed from the palate and then placed on the labial portion of the gingival tissue, the healing abutment, with bone graft underneath, and then sutured. And this is the healing with enhanced biotype and the gingival height at the midfacial level is maintained in relation to the adjacent tooth. And this is the healing, and this is with the provisional in place. And of course, the provisional is not ideal, but it's something that patient required during the healing phase. But what I'd like you to keep in mind is a gingival margin in relation to the adjacent teeth. It is very, from when you make a tangent line from here to there, is right about the same level in 2-week period. And this is 4 weeks later with the provisional in place. And this is with 6 months with provisional in place, and then the gingival margin, and this is initial visit, and this is with the final 1 year after the final restoration. Gingival margin is still within 0.5 millimeter from the original gingival margin after the implant placement. And when I looked at this restoration done by the restoring dentist, it was somewhat over-contoured, despite the fact despite that, the gingival margin was maintained 1 year after the restoration. And this is at 2 years after the restoration, at which time the two laterals got into restorative problems, and they require extraction and implant placement. So same type of situation where there's a caries lesion, recurrent caries lesion, and it was extracted and placed with dental implant in a one-stage fashion with the healing abutment using same technique with bone grafting, and the connective tissue was grafted on the labial side and sutured. And then on the contralateral side, same situation. The existing restoration was extracted, and then healing abutment placed. The void was grafted to about 3 millimeter from the gingival margin, a crescent-shaped connective tissue was grafted in the same fashion to enhance the biotype, and 2 connective tissue. The advantage of this technique is that the donor site heals very rapidly because there is a very short distance between the 2 epithelium. The site is packed with the calico type collagen dressing, and then 1 suture from here to here would keep the dressing in place, and in 1 week healing is very rapid. This is 2 weeks actually. You can see the original gingival margin with the connective tissue with survived connective tissue. Same thing on this side. Patient is wearing a SX type for the healing phase. Okay. And you can see that the connective tissue has survived. The gingival margin has coronally enhanced and horizontally enhanced. And then this is a 2-week healing of the donor site. Patient experiences very little discomfort with this type of donor removal, and heals rapidly. And this is 4 weeks. Oral hygiene is not ideal, but it doesn't seem to hinder the healing. And this is after the final restoration in place. And it wasn't designed that way, and many people frown on putting implant next to each other, especially between the lateral and the central. But because of serial extraction and placement, not intentionally, but because of the time sequence, the 4 implants are placed one next to each other. And this is 1 year later. You can see that if you look at the original gingival level, connecting from canine to canine, and the gingival margins of the extracted teeth, you can see that a tremendous amount of tissue has been preserved, the biotype has been enhanced, vertical height is maintained reasonably well, and certainly the labial gingival margin was maintained over at least 1 year period. In this case, I've been following for a couple of years, and there has not been a gingival change on these restorations. So this technique will provide an enhanced biotype with simultaneous implant placement of the dental implants, and maintain the mid-facial gingival level very effectively. And whenever we are placing a dental implant immediately in extracted sockets, this type of enhancement and compensation for possible gingival recession and mid-facial level should be used to ensure the long-term stability of the aesthetics around these dental restoration, implant restorations. All right, thank you for watching this, and if you have any comments or questions concerning this technique, please email me, and I'll be happy to reply back as soon as I can. Thank you very much.